most of it involving the ankle or the foot at this point. You'll see most of these on a very regular basis, especially the first two in the Army. Everybody's rocking, doing, some sort of PT, playing sports. So they're all pretty common. A lot of them are like sports med injuries. So I like sports medicine. So hopefully we'll figure this out together. All right. So we'll start with Achilles tendon tear. This is probably the most commonly, according to AI anyway, it's the most commonly tested tendon on the pants exam. So there will probably be, quite a few questions on the pants, maybe a couple on, the orthopedics test. It is a clinical diagnosis. And, what happens is you have that long tendon that kind of comes from the back of the calf, inserts on the calcaneus. And, mostly with like sudden sports movements, we're going to get some sort of rupture in it, or we can. The classic patient or board question type patient is like some middle-aged racquetball player, or some tennis player type person, somebody playing basketball. You'll see it a lot in your units too. Like, is it all Army in here? We got Air Force. Air Force. Oh, we got Air Force. Okay. I'm sure you guys play sports, right? Yes. No, yeah. You'll see it a lot in like it'll be your older, like in their 40s, not older, but older Army-wise, like in their 40s. It'll be like I've seen, who have I had? I have our shrink and our chaplain have had it. So usually a little bit older. It can happen in younger patients as well, so it's something to think about. But really what they complain of is like severe pain in their calf or like the distal calf. And they'll describe it like it's a gunshot wound, like somebody hit me in the back of the leg. And partial tears can present similarly as well. They may not have that same like gunshot wound type picture, but they'll come in complaining of pain on the back of the calf or lower extremity. And then what do we do? So like this is a very commonly tested exam that you're going to see like on the pants or board questions, and you're going to do it in real life. So it's we're going to look at doing the Thompson test. So first we're looking for any, first we obviously test, we start with our range of motion, which usually will be limited because there's all these fancy tests that we do for a lot of things, but most of them are pretty worthless in the initial acute period because there's so much pain and swelling. And like when you test range of motion, you get this extremely swollen joint, how are they actually going to give you range of motion? So something we always talk about, but in practice it might be a little different. This one, you might feel like a balled up, swollen portion on the back of the calf there, usually like, a few centimeters or 6 centimeters from the calcaneus on your exam. So that's usually a good indication there might be a rupture there. Then you have your Thompson test, which normally your foot, normally a patient when they roll on their belly, they're laying down, their foot will be a little bit plantar flexed. So it'll be, I guess if you're this way, I don't know if it makes sense, but it'll be kind of a little bit plantar flexed there. That's normal. And then if you think about it, because you have that tendon attaching to all those muscles and then down at the heel, if it's disrupted, your foot's going to come a little bit more into like a neutral position. So that's one indication too when you're evaluating them, that one foot looks different than the other. We have two, so luckily we can look at both and say, okay, one's sitting a little bit differently than the other, that might be abnormal. And then the Thompson test, we just squeeze on the calf muscle, and doing that should plantar flex the foot. And so that's a normal finding, that's what you want, that's a negative Thompson test. And then if you squeeze and nothing happens, that's a positive test. So pretty straightforward. I probably just took too long to explain that. All right, and then so one of the key things, this is a clinical diagnosis, so you don't need any imaging for it, you don't need an ultrasound. The good news is we do a lot of ultrasound now, and I know they're rolling out ultrasounds to Army units all over the force right now. So you guys will have the ability to ultrasound, but you don't need it. It is nice to have it at the bedside. You can take it in the room and you can look, and this is what it would look like. So hopefully, let me see if I got some, you do have some positive arrow findings on there, which is good. The middle one is, let me see if I can get my little pointer thingy on here. So right here is where we're looking at the rupture. So you got that little balled up tissue here, and then you have like, you can see like some free fluid there and a little gap. And then you see the tendon coursing down here as well, so that's indicative of ruptured Achilles tendon. You don't, once again, don't need the imaging. It can be helpful if it's equivocal. So you can get bedside ultrasound. If there's any like if the diagnosis is in question, you're not sure, MRI is like the gold standard to evaluate the tendon or really almost any soft tissue. So they may need one for like pre-op planning and things like that, but you don't need one. It's clinical. And what do we do for it? Well, not a ton. Really, it's going to be our standard therapy for probably, I don't know, almost everything in ortho. So you're going to do NSAIDs, rice, and then we want to know whether it's partial versus complete rupture. For partial, we're going to give them, some sort of activity modification, the rice therapy. We send them to physical therapy. We place them in a cam boot. Our goal here is to kind of, if you think about how that tendon runs and what, like when you're doing the Thompson test and squeezing and it pulls. So our goal is to kind of shorten the length of that tendon, so we'll have a little bit of a heel lift inside their cam boot, or if we put them in a splint, inside their splint. Usually we want them non-weight bearing for a short time afterwards. And then operative repairs are going to be for complete ruptures, but not everybody gets it. We'll kind of talk about it here on the next slide. We want to refer all complete ruptures. There's like, different evidence out now whether there's no difference between doing surgery versus non-op treatment. Usually if it's soldiers are probably going to do operative treatment, or athletes, we would want them to heal a little bit or recover a little bit faster. And that's what the big difference is. You can get a quicker recovery with doing operative management versus non-op. It'll take a little bit longer to heal for these. But we want to refer all of them with complete rupture to orthopedics. And they say in the first 24 hours, hopefully Davalos has told you they don't do anything. Unless it's like a surgical emergency, they're like, yeah, we'll see you in 2 weeks for just about everything you send there. But theoretically, it should be in the first 24 hours. And then adverse outcome, just like anything, you can get an infection, some sort of surgical site infection. You can have some, I don't know what it means on here by wound issues. I would probably call that under surgical infection. Those are going to be the wound issues you have. But, we do run the risk of re-rupture if we're doing non-op management, which is more common, and that's usually because the rehab, they didn't rehab it appropriately. They went on it too soon afterwards. All right, ankle sprain. This is like one of the more common things you guys are going to see. Most people have probably sprained their ankle in here, or at least had some sort of ankle injury. And we classify them in a couple different ways. The most common one is going to be our inversion injury. So they're going to, invert their foot like in the picture there, and we worry about those ligaments depending on what grade sprain they have. So you can see on there the different ligaments. So the most commonly injured ligament is going to be your ATFL, so that bottom, the anterior talofibular ligament. And on exam, this is going to be like when you're doing your exam, you're kind of pressing where those ligaments are, trying to identify where some of that swelling and pain is, can be helpful. More severe sprains, you're going to then tear your CFL, your calcaneofibular ligament. And then with those higher grade strains or high ankle sprains, you can tear the other ligaments, and they're less common. You do have medial ankle sprains or eversion injuries. They're less common, and they're oftentimes associated with like dislocation of the ankle or something like that. But you can also, tear one of those ligaments, but it requires a lot more force. What we worry about is a high ankle sprain knee. So we have that syndesmosis in our lower extremity between our tibia and our fibula. And we worry about some sort of rupture of that syndesmosis when we're doing these. So we'll talk about during the physical exam here in a second, but we want to rule out those high ankle sprains. They have a lot more sequela and a higher risk of fracture and other injuries with it. So they'll require a little bit more rehab and therapy if that happens. But most people roll their ankle, they come in, it's swollen, it's painful over those ligaments. A lot of patients will say, I felt a pop. I think like every patient told me, I felt a pop. Somebody told me over the weekend it was like completely dislocated, but she's walking fine. And I was like, I don't know about that, but maybe. One of the things we want to watch out for, like if they have any inability to bear weight, because we're going to talk about the ORTHO criteria, which is going to be our imaging rules, and that's something you guys need to know for the ortho testing for the pants. Like the ORTHO ankle rules are like a commonly asked question, and it's something you can use in practice. I'm very guilty because I'm in the ER. We just image everything. I don't care if they're ORTHO negative, positive. our physical exam, we'll see, a lot of swelling. You'll see that ecchymosis, like I don't know if I see a bunch there. On the first slide, we had a bunch of ecchymosis, so it'll be dark. You'll see, the blood vessel in there ruptured when they inverted their ankle. Then you'll have a ton of swelling. We do a couple special tests for this one, which you can kind of see on there. The one of them is that syndesmosis squeeze. So we always want to check that during our ankle exam for any high ankle injury, and we want to rule that out. And then like I said, you palpate those ligaments and kind of see if you can localize the pain and where it is over those ligaments to kind of help grade what kind of ankle sprain they have. And then for fracture, we use the ORTHO ankle rules, which should be on the next slide here. The other test they're doing is just external rotation. So they're squeezing up at that syndesmosis and they're externally rotating. And then if you're getting pain up where your hand is, that the left hand there, then you may have a high ankle sprain. But here's our ORTHO ankle rules. So these are something important to remember. So one of the criteria is, can they bear weight? So any inability to bear weight, get an x-ray. Next one is going to be any lateral or medial malleolus tenderness, but it's over the posterior 6 centimeters. And really, how do you judge that? Let me measure 6 centimeters. Really, if you got any bony tenderness on that posterior portion of the medial and lateral mal, we want to get an x-ray. If you have any tenderness over the base of the 5th metatarsal, we want to get an x-ray on them. And then if you have any pain over the navicular area on palpation, that would be a positive, ORTHO criteria to get an x-ray on these patients. So it's important to know that, and when you wouldn't get these x-rays for a test. In real life, yeah, we don't need to, but sometimes imaging is like therapeutic as well. So, that's something we don't talk about a lot, but, patient satisfaction is important. So, in the ER, we just image everybody because that's what they want. Hey, say it. All right, so what do we do for these? Almost all these are going to be non-op treatment, especially in any acute period, unless there's some sort of associated fracture with it. And we'll talk about fractures in a different lecture. But we have our, our goal of treatment is really, it's chronic pain and instability. So you'll get a lot of patients who have their chronic ankle rollers, and that's because they never rehabbed it appropriately. And so those ligaments are kind of loose. They didn't regain any of the strength and range of motion they had. So it's important to understand the 3 phases. So initially, they'll likely be non-weight bearing. So we'll place them, we'll give them NSAIDs, we'll give them rice therapy, and then we'll place them in some sort of brace or stirrup. And a lot of times we have little air casts and a lot of different braces out there you can use. And then we want them to be non-weight bearing, usually for 1 to 2 weeks. And then once they start, once they're able to ambulate without pain, then we start working them into range of motion and strengthening exercises. What's important is not to keep them in a splint for too long, because then you're going to get atrophy of a lot of those muscles, and it's going to be harder to rehab it. So one of the ways that I tell the patients, initially the first 1 to 2 weeks kind of stay off it, but start after that range of motion, so have them trace the alphabet with their foot. That's a good one to just get the movement kind of going around in that area so that you're not atrophying. Then we can send them, you can either give them a home exercise program to start strengthening for range of motion and strength, or we can send them to physical therapy to start rehabbing that. One of the important things to remember is the reason we have these adverse outcomes usually in that phase 3 of rehab, they don't do it appropriately, and so those patients will have chronic instability and pain afterwards. So that's what we're trying to avoid here. Talk about bunionette. It's also called the Taylor's bunion. So this is going to be that kind of deformity over the 5th metatarsal. Common in, more common in females or anybody wearing tight shoes. And for almost all of the foot problems you see on here, it's usually something to do with their shoe or footwear or tight shoes. So it's important. We tell them not to wear any narrow shoes, anything with high heels when we see this. But really you'll have a prominence of that 5th metatarsal head. It'll start to deviate that toe more medially, and that's it's usually pretty prominent on exam. You'll kind of see that
bone sticking out there or that tissue sticking out. They'll have pain over it. One of the things though, they shouldn't have pain once you remove the shoe. It should be less painful on exam, but you should have the obvious deformity. You may get a corn or like a bunch of rough skin tissue over it because of the frequent friction kind of creates all this extra tissue on there. And then here's what it looks like on plain film, so hopefully everybody can see that. Definitely looks abnormal on there. That angulation is, not the appropriate area. You have like your joint space is increased in certain areas. And let me see if there's, okay, I don't think we need to measure an angle on this one, but you can measure like a 4th to 5th intermetatarsal angle, and probably not something you guys need to know, but it's more of a physical exam diagnosis for these. But really, what do we do for them? Same thing we do for everything, and says rice. This one, the big thing is getting wider shoes. Usually helps fix these. There are different kinds of pads you can give them. Sometimes we give them a referral to get inserts made for their shoes. And then if they fail non-op treatment, then we need to look at referring them for possible surgery. The good old diabetic foot, man. So this is nasty for one, but obviously we know diabetes is like responsible for everything, it seems like, or has some sort of poor outcome for everything when they have poor control over their glucose and their sugars. But it is a common reason for amputations in patients. We worry a lot about skin ulcers and infections. So they have, because of the altered neurologic findings or neurologic developments plus vascular developments, like you can have very poor outcomes with wound healing. These patients, they can be very tough to treat. All right, so what does it look like? So you can get ulcers, we can get like Charcot's, arthropathy. We worry about like cellulitis and infections as well, and then get osteomyelitis or bone infection, which is a lot more difficult to treat. So our goal is to hopefully prevent this. That's why we do those little foot checks, and we use our whatever monofilament test on these patients when they come in for their appointments, because a lot of them won't notice this, especially when they have these comorbidities. They're usually like very obese. So I don't even know how some people get shoes on sometimes. So they may not have seen their feet for a long time, and if you no longer have sensation there, then you're going to end up with something like this. But they're not going to be usually complaining of pain. It's going to be something we have to check. So you'll see the skin breakdown, usually over an area that has more pressure on it. So depending on how they're, whether they wear tight shoes or not, whether they wear anything in heels, it'll kind of depend on where you see this injury. If it's any sort of infection, it's going to be like hot, red, warm, tender. So that's something we want to evaluate for as well. Sometimes we can have Charcot's, which can present hot, red, warm, and tender, and one of the differentiators, we can elevate the foot, and that erythema or that redness will decrease or disappear, and that can help us differentiate between a cellulitis, which shouldn't, it should stay hot, red, warm, and tender when we elevate it if it's a cellulitis. So that's something we can do at the bedside easily to assess for this, but we also want to worry about those other like really adverse outcomes like an osteomyelitis, any sort of infection like a Charcot joint. So those patients may have to get an amputation. And one of the things that's important, don't assume it's Charcot's just because they have diabetes. Like a Charcot foot, I was like looking it up because I was like, we always talk about this and like how common is it? So it's kind of confusing because they say it's the more common of the rarer diseases, which is like funny. I'm like, what does that mean? So it's like 1 in 3,300 might have it. Not because I was thinking, I was like, I ain't never seen this, but I sure have been tested on it, learned about it, worried about it. So how common is it? They say if there's like 1 million people, there might be like 300 who have it. So maybe that's why I haven't seen it. They just haven't showed up. But what you see on here is they start to lose, or they start to get joint destruction and bony fragmentation, and so then it starts affecting the joints. You get the collapse of the foot or that rocker bottom on there. And on an x-ray, you'll see like fragmentation, possible dislocation, sclerosis of the bones. You know, the big thing we worry about is a cellulitis or an acute infection versus a chronic Charcot's arthropathy. So it's always better to err on the side of caution and treat that infection. But like I said, if you elevate that foot and it stays red, then you want to think maybe that's a cellulitis versus like a Charcot foot. And then here's our physical exam test. It can be difficult because they don't have sensation down there. So a lot of times we're evaluating patients like, does this hurt when I poke here or there? Well, they don't really have that sensation here. So that's why we want to test them and see if they have that protective mechanism versus not. And usually if they don't have, you're gonna notice immediately because they're gonna come in either in pain or it's gonna be painless and you notice it on physical exam. You can do your nylon monofilament test. I haven't done one, I think, since phase 2. But that's because in the Army, you know, it's usually young, healthy dudes. So we don't see it as often. You know, I think I had maybe 3 people with diabetes when I was a battalion or brigade PA over my 5 years doing that. And then in the ER, it's usually some sort of acute condition or infection. And then here's what it looks like on plain films. So kind of like what I said earlier, you'll have like some of that bone erosion, joint, it'll sort of involve the joint space, joint erosion, and then you'll see kind of that collapsing, sclerosis. One of the issues we want to make sure we, consider is an osteomyelitis or a bone infection. If, you don't have any pulses on there, we consider some sort of vascular imaging study. So, some sort of, CT, angiogram might be something reasonable. And then if we're worried about a Charcot and osteomyelitis, we can get a bone scan. That's going to be our best test for that. And on a bone scan, it'll be cold for Charcot's and hot if it's osteomyelitis. So you'll see increased uptake on there. All right. So what do we do for it? Most of it is going to be non-op treatment unless we have some sort of acute infection or osteomyelitis that is not responding to therapy. But the best thing we can do is have them get good control of their sugar or their glucose. So we need to make sure they're on the appropriate medication, they're checking their blood sugar multiple times a day. What's nice is a lot of times patients have continuous glucose monitors now, although some insurances don't cover it. So we just want to see if they have a good sugar log. If not, we need to start managing them appropriately. There are diabetic clinics in a lot of the hospitals that will help manage them for you, which is nice. Once again, larger shoes, I'm telling you, everything involved in the foot. Just get bigger, wider shoes, man. It fixes most things. We can do casting for it. And then if there's concern for a deep abscess, we would send them for operative management if it's not something we can train ourselves, which usually isn't with these patients because they have all of these comorbidities along with it, and usually it's deep down and possibly in the bone. And at that point, they'll look at an osteomyelitis, and then they might operate on it by removing that bone because it's very difficult to treat those infections, especially when they're this far distally and they have that porous vascularity or circulation already. It's gonna be difficult to keep that extremity. All right, so when to refer them. So they're usually going to be in sensei, so if they have some sort of unexplained pain, if it's sudden onset, then you need to think about some sort of infection, and then those non-healing ulcers, we need to get them appropriate therapy, and there's a lot of great wound care clinics that most of our hospitals have. They're going to manage those kind of deeper non-healing ulcer infections. But it's very difficult to treat. It's a long process. They're following up with that wound clinic for months, if not years, to heal it. But if there's any of them with a non-healing ulcer, then you need to consider a vascular surgery referral. It's not really an orthopedic problem at that point. So that's just another console we have to place in there. All right, hallux rigidus. So you got your first metatarsal, and
throughout time, you can get, arthritis, repetitive injuries to that area. Then you start to get like some of those osteophytes or other bony conditions associated with arthritis that then kind of go into the joint and you lose your mobility of it. So we judge it by what the range of motion is for this. So you can see on the top, we got normal range of motion. And then we judge it like, is it hallux limitus versus hallux rigidus? So rigid is you don't get any movement in that area versus limitus, and that kind of guides the orthopedic treatment for them, whether we need to send them for referral for surgery versus managing it non-operatively. But loss of that extension is going to be like our hallmark finding for hallux rigidus. And then they'll complain of some sort of pain in their toe, normally with toe off, so while they're walking, because they have that limited range of motion, you're leaning forward, your joint doesn't bend like it used to, so it causes pain. And then you'll, on x-ray, you'll see that like, you'll see those osteophytes in there, and you'll see, signs of osteoarthritis that would be indicative of a hallux rigidus. All right, and here's what we see on imaging. So these ones, you're gonna get like your AP and lateral, usually weight bearing for most of these conditions unless it's an acute issue. So this is normally gonna be a lot more chronic. So you guys kind of see those findings on there. You have a bone spur on the left, and then on the right, it looks like you've got some kind of erosion there. I got the dorsal lip, I would say that, x-ray. So that, all of those are signs of OA, and then you add on their limited range of motion, we call it hallux rigidus. Treatment, once again, for everything non-op, large, wider shoe. I feel like it cures, in real life, I feel like it does fix a lot of problems. Like a lot of foot complaints, and we'll talk about like plantar fasciitis and all the other foot conditions that we commonly see, especially with athletes. And most of them, I tell them just buy new shoes, and a lot of, I'm telling you, a lot of new shoes and wider shoes fixes a lot of problems when you're talking about the feet. So our goal, once again, RICE, NSAIDs for everybody, and then we'll have some sort of activity modification and then physical therapy. We like to manage pretty much everything non-operatively, especially for these more chronic problems. And then when they can do steroid injections, usually that's done by orthopedics or sports medicine. It's not something we do in an outpatient clinic basis. You got to be careful when you're injecting joints, especially in an outpatient setting. You guys will do like knee injections, things like that, but other than that, we're pretty limited in what we want to do in our outpatient environment, just because you have complications, infections, damage to other structures. There's a lot of things associated with it that we don't want to risk doing those in clinic. And then the surgery they would do for these, they would cut out some of that bone, try to clear up that joint space, and then hopefully gain some range of motion back, or they'll completely fuse them together for severe disease. All right, then we're looking at hallux valgus. So this is going to be the bunion. We talked about the bunionette already. This is similar to the bunionette, just on the opposite side. So this one's going to be that first MTP joint. You'll have a painful bony prominence that patients will come in complaining of. It is the most common malady of the great toe, so it is something we're going to think about. Females, more common than males, are a lot more common. And then they'll complain of usually pain with shoe or footwear. You might see a callus on there, and then sometimes you get numbness, depending on their footwear preferences. But one of the things we want to do is look at the range of motion. Usually you can see these pretty clearly on your physical exam. We also want to look at the other toes, make sure they don't have any associated other maladies with it, like hammer toes or deformities. And then here's what we see on the imaging. So these are important things to know what the degrees are on these. I remember being tested on it. I don't know that I've ever measured it. Luckily, the radiologist report will give it to you, but it's important to remember normal less than 15 degrees. So we look at that hallux valgus angle.
So you see it on there, the HVA, so this one's at 30 degrees, so we're measuring that and then intertarsal angle, or intermetatarsal angle, so normal is less than 10 degrees. These need to be weight-bearing films, just about everything for chronic foot issues are gonna be weight-bearing films. So once we get that, we can diagnose them and we manage it pretty much like everything else. I feel like I'm like a broken record up here. So NSAIDs, rice, activity modification, and then roomier shoes. This one is important because hopefully they can be asymptomatic once we give, tell them to avoid certain shoes. We also have other therapies. There's little splints you can wear. There's toe spacers that can be helpful for these patients. But the big thing is going to be education and telling them don't wear narrow shoes, avoid high heels. You want to, if they have a flat foot, you want to look at getting them inserts for their shoes. And then once if it becomes severe enough, then they can look at doing surgery for these. And they would really just do an osteotomy, cut the bone, and then re-angulate it appropriately at that point. Morton's neuroma. So this is a fun one. So this is going to be a common one you're probably going to see as well and something to consider. So you get like some sort, it's not like a real neuroma, but you get like fibrosis in between those, in between your metatarsals in your foot. And then it can cause issues with the nerve that runs through there. Most common third and fourth, between the third and fourth toes, so your third web space. It can affect other web spaces as well. More common in females. You'll probably more common in athletes. This one's, usually has some sort of nice differentiator, especially when you're reading test questions. Like it feels like a wrinkle in my sock, or I'm walking on a marble. And then, usually just foot pain on the plantar portion is going to be your most common symptom that they show up with. Once again, it's irritated by, high-heeled or tight shoes. So one of the things patients will a lot of times tell you is if they're wearing like, flip-flops or something like that, nothing that's restricting the foot, that they'll be asymptomatic at that point. And then here's what our common test is for it. So, we want to palpate and kind of isolate where that area is. And then we do what we call the squeeze test. So we just take our hand, we squeeze the foot. There's also like a finding, so it should reproduce the pain. There's also a finding called like Mulder's click that you'll sometimes hear when you squeeze that foot as well, and that's going to be a positive finding or a sign that they have Morton's neuroma. And then you want to look for other issues that can cause, plantar foot pain like calluses. So this one, we can do our rice therapy for it, and that's what we start with. So it's easy to start with non-op therapy. A lot of times we treat, athletes or people who are very active. So sometimes we will do steroid injections. I've done steroid injections on these. And they can be diagnostic and therapeutic. So, if we inject it, it has lidocaine and some sort of steroid, one of the steroids in there, and it'll improve their symptoms. So, that can help us with the diagnosis too, that, yep, definitely Morton's neuroma. It improved their pain after I injected it. And I guess if it isn't, then you're like, okay, well, it's not Morton's neuroma, that didn't help. Which happens in medicine, right? And then operative management. I'd be interested to know how often they do that, because I never had anybody really fail like outpatient therapy or steroid injections, but all right. Man, we're already done with that lecture. I like it. So here's what we covered today. So big things to think, like indicators to think about, especially when you're like looking at test questions. There's a lot of the foot stuff's the same. Like, does it hurt on the bottom, does it hurt on the top? It's like an Achilles tear. You're commonly going to see like a middle-aged person feels like they were hitting the back of the calf or over the Achilles. They felt like a gunshot. Or like, usually a racket sports player, like tennis, racquetball are common ones you see on like board questions. One of the things to remember with, I don't know if I mentioned it for Achilles tendon tear, don't ever inject a steroid near the Achilles tendon because you run the risk of causing a complete rupture. Ankle sprain, remember your Ottawa rules. So, any inability to bear weight, tenderness of that posterior medial or lateral malleolus, tenderness over the fifth metatarsus, the base of the fifth met, where like a Jones fracture would be, or navicular tenderness. Get an X-ray on those patients. You want to remember, always rule out a high ankle sprain. It's got a longer recovery time for that. You know, the bunionette, that's going to be fifth MTP. You should have a deformity, wide shoes. We really don't do surgery on it. The diabetic foot, like big things, especially for pants and board questions, like a hot versus a cold scan, Charcot, hot, osteomyelitis. And then you want to think about your elevation test for Charcot versus a cellulitis. So if I elevate it, the erythema improves. I'm thinking more Charcots. For hallux rigidus, it's pretty easy. I mean, they can't, there's no extension in their foot. Or in their first MTP, we lose extension. And then those ones we can, you know, if it's a hallux rigidus versus limitus, then we can look at referring them to ortho. Hallux valgus, remember your like HVA angle less than 15, and then your IMA less than 10. Morton's neuroma, you know, squeeze the foot, Mulder's click. We can do a steroid diagnostic and therapeutic. And then I think that's about all I got for this lecture. We'll move into the next lecture. We'll take a 10-minute break. So if you guys want to be back at 10:50, does anybody have any questions? Are you guys like a question class or not? No? You guys are like, whatever, just get off the podium so we can study. What test you guys have next? Oh shit, you guys probably like you're not even listening to me. You're not all right, yeah, be back at 10:50. I'll stick around for questions if anybody is embarrassed to ask them.
At least they understand.
Well, we know it's big.
No, but this is just like a habit. Right now we're at what? I'm thinking we do like 70, 75.
I was looking at it.
He just got done.
I mean, when I refer as like chronic,
But he got, so he can explain this all.
So I just divided to 275.
But he's not going to show, he can't divide it off. That seems like a next lecture,
Actually finishes that year.
even some people
well, I'm just saying in general, like, if it doesn't matter, let's say there's a small difference, longer, I think just give you
Yeah, that next one is only like 75.
that's all it's
So let me know. Like, I kind of stab them one way or another. Or it goes, just let it go on some day instead of rain.
She asked me about like the time frames of the plug-ins for control, and it was very slow. I don't know.
All right, you guys ready to get rolling? We got everybody?
Colonel Fritz is gonna talk to you guys real quick.
Hey, everyone, I just want to come by and introduce myself. I'm not officially here yet. I'll change patches probably later this morning, but if you guys know Colonel Sylvester, he's a Army Senior Service Rep. Unfortunately, he suffered a medical problem. Is likely not to join us back, significant enough. So that sucks. We had originally planned I was going to come in as a replacement for Colonel Sylvester later this year. I ran over here early and thought I was going to have some transition time, but I hadn't. So right now I'm going through his desk, I'm finding pieces of papers with some of your guys' names on, primarily Army, Air Force, Navy, you guys are all good, your senior service reps in place. But I'll be taking over a few, like, so like right now. So, if you guys have any problems, issues, I am effectively your link to the UCJ authority for the Army, so Army Reserve, National Guard, and active duty. So I handle admin, academic and non-academic relief things. I hope we don't have to move that way. I also am doing good fun things. So if you're working on parental leaves or you have some other thing going on, I'm ultimately in your link pathway, right? You got your individual counselor and then your class coordinator, and then eventually you'll chat with me. So I am over here in the senior service rep office. Please feel free to stop by and say hi. If you got anything you want to talk about, I'm happy to. The second time I've given this speech, I gave it to the freshmen. It was much less impressive. I was like, I handle all the relief and recycle actions. They get terrified of them. I'm going to have to talk to them again. So if you see the freshman out there and like, oh, he's a jerk, he's not a jerk, he's cool. Go talk to him. Any issues, please let me know. If there's something that you submitted into to Colonel Sylvester and you're like, I haven't heard about it, it is possible. It's lost in his email. He's not logged into his work email. I did go see him yesterday. He's looking a ton better when he first had this incident happen, but he's still not ready to come back to work. So. If you anything at all, please feel free to stop by. I look forward to working with you. I know you guys are coming up on the end of the junior semester. I've actually told the story twice in the last 45 seconds. I know you started as freshmen. You're probably working out, running together. You're moving into that time where I remember in this course, it was wake up at 3 in the morning, plan for a test, walk out with a zombie, get a breakfast taco, come back and listen to the lecture for the rest of the day. That's coming for you. Don't let it bite you. You're going to get the next phase of your training is going to be part of it. Take all this stuff, push it together with actual human beings, and see the condition of the treatments. Okay? I look forward to working with you guys. I'm glad to be here. Next summer, I'll take what you guys won't care, but next summer, I'll be the program director, so I will be the senior service rep when you guys are out of phase 2. So, unfortunately, you find yourself in trouble out there eventually, so that's across my desk. Also, though, if you go out there and kick butt and do great things, you stuff across my desk. Okay? It's nice to meet you. I'm sorry to interrupt your lecture.
Oh, you're good. All right, let's move on to the foot. More foot complaints. So, key things to remember with all these orthopedic things, especially like the foot and ankle, like almost everything sounds the same, similar symptoms, similar pain. Key differentiators are going to be like your classic presentations, like I said in the last one. So like, walk like a wrinkle in my sock, walking on a marble or a pebble. And then you want to know like your can't miss diagnoses and your first line treatments for most things. Orthopedics I think is like 6% on the pants, so not a huge number, but in our population it's like a very common thing we see. That was one of the reasons I did the emergency medicine program, because all I did was like orthopedic complaints, the snivels, and maybe some rashes throughout the year. So your skills kind of atrophy in the Army. Luckily, I think the Air Force gets to work in like family medicine clinics, so I get to see like a larger population. But it really kind of sucks for us in the Army because you lose a lot of what you learned in phase 1 once you leave phase 2 because you never manage it. All right, here's what we'll talk about today. Most of these are very common, or I want to say all of them are pretty common, other than like maybe the toe deformities. I see these all the time, still see them in the ER all the time. So we'll talk about metatarsalgia, plantar fasciitis, warts, that posterior tibial tendon and sesamoiditis, some deformities, and then turf toe. All right, so we'll start with metatarsalgia. So just like the name says, it's involving the metatarsal heads, and it causes some sort of inflammation there, so they'll complain of forefoot pain, usually over the 2nd through 5th metatarsal heads. Why not the first metatarsal head? Anybody know? Because we'll talk about it here in a second. Yeah, so this one, yes, because the sesamoids protect that area. So we'll talk about that shortly. All right, so this one is going to be very common, especially in runners. So anybody with repetitive force, your foot's slapping down on that area and you're going to cause some sort of inflammation or irritation to that area. It'll be on the plantar aspect of the foot. You can also see it with deformities, which hopefully makes sense if you have some sort of different angle in your toe or disruption in any of those ligaments. You're going to have more force applied to another area of the foot, and it can cause metatarsalgia as well. You can get fat pad atrophy of the metatarsals, and then a callus can also irritate this. Most of these are going to be activity related. On exam, it'll be on the bottom or the plantar aspect of the foot. And this one, they'll say like I'm walking on pebbles is what the common complaint is, but it's over the 2nd through 5th metatarsal heads, not the first. And then this is a clinical diagnosis, so they'll have on palpation some sort of plantar pain on your examination. You want to observe their toe alignment, range of motion. You're going to look for any calluses on there. And then, if you're getting imaging, you want to get weight-bearing AP and lateral films on these patients. And this is really looking for that, at those metatarsal joints, looking at toe alignment or any other condition that could cause this. This is kind of a diagnosis of exclusion. We want to rule out anything bad when we're looking, when we're evaluating these patients. Once again, treatment, same as I feel like almost every condition we've had so far. So some sort of NSAIDs, rice therapy, activity modification. This one we want to tell them wear wider toe shoes, roomier shoes, but we can put like a metatarsal pad in their shoe like it has on the picture there. So this takes some of the pressure off those metatarsal heads, and it changes the force when they're walking or landing. So that can be helpful for these patients. If they have a callus over that area, we can pare down that callus. So we take a scalpel and we just remove some of the layers of skin over it to help reduce the pressure that it's causing. So we try to pare it down until hopefully it gets back to its normal size. And then operative repair, they, for severe conditions, they can do like, toe and metatarsal head realignments, plantar plate repairs. Fortunately, I've never had to send anybody for repair of metatarsalgia. Usually these more conservative measures improve this. Anybody had this here? I've had it. It's not, whatever, it's not fun. I'm a big runner, so I've had it, a few times. It's irritating, but it's, not disabling. And then this is gonna be the most common cause of heel pain in adults. So plantar fasciitis, you're gonna see this all the time, especially in our population. So common with ruck marching, running. And it's important just to remember where the plantar fascia is. So it rises from that medial tuberosity, the calcaneus, and it kind of runs on the bottom of the foot to the proximal phalanges. And it provides support or an arch. What's up?
Hey sir, when it comes to the callus, would that be more of a protective factor?
I don't think so, because you're applying more pressure, so the callus kind of builds up. So it's gonna, every time you strike, it's gonna add more pressure to that metatarsal head, and it irritates the symptoms. All right, so you see this more common in overweight patients, females more common than males. And they, there are other causes, like they can have a plantar fibroma or mass, which is less common. This one, so on their presentation, most of them are gonna complain of like first step pain in the morning that improves after they're ambulating for a while. So that's common on your like test question, PANS questions, worse in the morning. So for this, on your exam, they usually have some sort of tenderness to a specific area on the calcaneal tuberosity. They may have pain along the fascia. Like I said, most intense in the morning. It starts to improve as they walk throughout the day. If they sit for a long period or drive for a long period, they'll commonly complain of that pain worsening. And then here's where your pain is typically located. So it's kind of more on that like the medial calcaneus. So it's typically not as distal, so you're gonna kind of press into that area and reproduce their pain. Sometimes it can be a couple centimeters more distal to it, but typically it's gonna be exactly in that spot where the star is where you're gonna reproduce the most pain for these people. A lot of times, so if we look at like the mechanics and how that plantar fascia stretches, a lot of it is associated with like an Achilles tendon tightness. So for some of these, like I did a like a dry needling course, if you guys know what that is. So we take a acupuncture needle and we place it into a muscle, and it causes it to like fire and relax. So a lot of times I can fix their pain by just dry needling the calf muscles, because that's what's causing the tightness there, and its downstream effect is going to be that plantar fasciitis. So I always like to check their Achilles tendon as well or their calf muscle and Achilles for any tightness in there, and we can fix that. But one of the other exam findings, if you passively dorsiflex the toe, it's going to worsen their symptoms as well. That's going to be positive in plantar fasciitis. So you don't need to get x-rays to diagnose this. A heel spur is not the cause of this, so don't tell the patient it's that heel spur in there. Because over half the patients aren't going to have a heel spur, so don't try to confuse anybody with it. If you're getting imaging, you obviously want imaging if you're going to be injecting anything or doing a steroid injection. If you have any like strange cases or atypical, you could get an MRI. And then for this, once again, non-op treatment. So we have different sort of, we can order like orthotics for them. We can do night splinting as well, so they can wear this splint overnight, and that really is just helping stretch out that calf and Achilles. We can do a steroid injection. You just want to avoid repeated ones because you run the risk of causing further damage to that fascia down there. But it can be helpful doing a steroid injection. They have shockwave therapy, so they shoot like almost like an ultrasound type beam into there. Everybody I've seen it done on, they can't walk for days. It looks super painful. I don't know how well it works for it, but you know, when I see this, I usually tell people, buy some new shoes, buy new boots. That's usually the first step, and that'll usually improve this. It is persistent most times, so it may take months to heal. So continuing with that NSAIDs rice therapy. Sometimes I have them use I have them freeze a water bottle. They can roll it under their foot, can be helpful for this condition as well. But most of our therapy is going to be non-op. They can do like fascia releases and things like that if they fail non-operative therapy, but we usually want them to at least try to manage it, 6 to 12 months first on their own. And patients aren't very compliant with nice ones. Like, do you want to wear that big thing to sleep? Like, that would be kind of difficult. And a lot of times you'll see this bilaterally as well, especially in like those athletes, runners, things like that. So you'll have to treat both of them. All right, let's talk about some warts. So you get warts on the feet, plantar warts, caused by the same thing as other warts, so HPV. I like to tell patients it's like a sexually transmitted infection for your foot. No, I'm just kidding. But a lot of times you see it in younger patients, athletes. You'll see it in people who walk barefoot a lot. They share showers, so you will see this. Like, you'll see it deployed, things like that when you're sharing the showers. If people aren't wearing their flip flops or anything on their feet, you see it in a lot of younger patients too. So I've seen a lot of pediatric patients or kids because they walk around barefoot. Especially like, water parks, things like that, you can get this. One of the key things we want to think about here is it a callus versus a wart? So they can sometimes present similarly because you can have a wart and then it kind of grows a little callus over it, so it can be kind of confusing on presentation. But this is what it looks like. You got some sort of hyperkeratotic lesion. HPV is the cause of it. And then usually younger patients that are more barefoot more often are sharing shower rooms, locker rooms, things like that. They will be painful, so the patient, will complain of pain on the plantar aspect of their foot. Sometimes they're very clear, like this one, and those are definitely warts on there. But sometimes it can be a little bit more difficult. So one of the things we want to look at is those papillary lines. So do you guys see the skin lines kind of running around that wart on there? So normally you should have the lines continuing over it, so that's usually one of the differentiators. If you see those papillary lines running over the lesion, you think maybe more callus, but like I said, sometimes these can callus over and be difficult. So we may have to pare them down before we can identify it. If you pinch both sides of the lesion, they're usually going to complain of some sort of pain. And then sometimes we may not diagnose this till we pare it down. So you see those like little punctate hemorrhages on there once you pare it down, and that could be indicative of like some sort of plantar wart on there. They start with a single lesion because of the trauma, then the repetitive walking on your foot, it's going to then spread to other areas of the foot. Most of the time I see it spread to other areas is the patient tried to take care of it themselves, and then all of a sudden it just exploded into a bunch of other lesions on the bottom of there. Because when we pare these down, we have to be careful that we're not spreading those viral particles anywhere. So we don't want to pare too deeply, or else we run that risk of spreading that virus throughout other areas of their foot. And then if you have to send it for pathology, I guess that's what it would look like under a microscope. We usually don't need to send these to pathology. If there's like an atypical presenting lesion and you're worried about like some sort of cancer, then you can do a biopsy on it. Otherwise, this is usually a clinical diagnosis. We don't need any lab work or biopsy for these unless we are concerned for malignancy. All right, so for these ones, there's a bunch of different options we can use for treating these. One of the more common ones on there is cryotherapy, which you can see in the picture there.
If we're doing anything for it, we want to, even cryotherapy, we usually want to pare that lesion down a little bit because it'll get some skin kind of calloused over it. So we pare it down and then we shoot it with some liquid nitrogen. It can be painful for a little while afterwards if we're using that cryotherapy. There are other options like electrocautery. If you're using like electrocautery, you gotta, one of the things they always say is to wear a mask because you can spread those viral particles into your airway. Then you can get like warts on your like vocal cords and things like that, which sounds horrible. I would not want that, but I think I saw in phase 2 on some people, and when I was in my ENT rotation, I was like, oh my God, that's not good. So then they have some sort of vocal cord dysfunction because the lesion's on there and they can't talk appropriately. If you're going to be doing some sort of ablation, you want to worry about, not going too deep. You always want to, talk to the patient about signs of infection. If they see it, they need to follow up with you. But something you guys will see super commonly, you'll shoot a lot of liquid nitrogen throughout your day. And it's just, you fill a little bottle and the spray shoots out and you hold it on for a few seconds. You can use some sort of like keratolytic agent like salicylic acid. Has anybody ever heard like, oh, just put some like duct tape on the bottom of your foot? Like that actually is a therapy and it does work. So you can have them try that as well. All right, posterior tibial tendon. So, we have all our different tendons down there. Well, this one runs on like the medial side of your foot and ankle, and it's what's responsible for the arch in your foot. So it's the main supporting structure. These are patients they'll show up complaining of some sort of like medial ankle pain without a history of trauma, and you can usually kind of reproduce it. You see it more in like middle age or overweight patients. Like the classic patient is that like overweight female, usually a little bit elderly. And the issue is it can result in complete collapse of that arch and flat foot. I also see it pretty commonly in like athletes as well. So you get irritation of that tendon as well. So other risk factors like diabetes for everything, right? But if they have like multiple steroid injections, they have a higher risk, high blood pressure, all bad comorbidities that can increase the risk. But they might have pain, swelling. Usually they don't have pain, that's why they're showing up. You may or may not see swelling with it, but if you do, it's along the medial ankle. But what we worry about is that loss of arch and then the ankle rolling in while they're ambulating. Most of it is an insidious onset, no trauma. Then the end result is that progressive flat foot. And here's what it looks like. So this is something, common board question, like the too many toes sign is something that you always want to know. So that can help differentiate it. You got medial ankle pain, no trauma, and then you got too many toes sign when you're evaluating them from the like behind the patient. And one of the tests we can do is like a calf rise. You can have them do a calf raise, and that's usually going to cause an increase in that patient's pain. But so like pathognomonics, like single heel raise, and then like on their tiptoes, and then if you reproduce that pain or tenderness along that posterior aspect of the medial mouth, then that's kind of classic for this. Just remember the too many toes sign, think posterior tibial tendon dysfunction. And then for these patients, we want to evaluate the rest of their mechanics. So we're looking for those weight-bearing AP and lateral, so we want to look for a flat foot. You want to look for like a high arch as well, so pes cavus. And then they can look at alignments of the other joints. We usually don't need an MRI, but if it's one of those equivocal cases, then we want to consider it. You guys know what equivocal means, right? I say that because we put words like this on the test, and somebody will raise their hand like, what does equivocal mean? And I'm like, last time it happened, I was like, it means inconclusive. And they're like, what's inconclusive? I actually would have vocab on, like at the beginning of my slides for sometimes when I teach it, just going over those common words that like we confuse on tests.
I always joke we should have like a thesaurus in the back of the room during tests, and people can like stand up and walk back there and look at this thesaurus. I mean, I don't know if they'd be embarrassed to, but I think it'd be fun. All right. So in this one, we do our same non-op treatment, so activity modification, rice, NSAIDs. If it starts to become severe, what we worry about is complete loss of that arch. So for those patients, we might look at doing like a cast for them. So we can avoid that. We also look at, some sort of orthotics for the patient. We don't want to inject this with steroids. And then one of the ways we evaluate it for operative repair of whether, they still have motion in that area, so whether it's rigid versus a flexible deformity. But really, if they fail outpatient therapy, that's usually something we refer to ortho. Or if it's any like acute recent onset flat foot deformity. All right, here's the sesamoid like I was talking about that protects that first MCP, which similar like the metatarsalgia, but it's just in the first MTP and it's irritating that joint. If everybody remembers, we have like little bones there. There's two little bones under the first MTP, and it connects the tendons there, and it's like a pulley system that gives it a little bit more strength and range of motion. I had to Google it because I was like, what does a sesamoid even do here, right? Like, why do we just have these random bones embedded in tendons throughout our body or in a couple places in our body? All right, so this one's going to have pain on the plantar aspect of the foot, usually from some sort of repetitive motion, and then sometimes people can have sesamoids in other areas, so it can be helpful for imaging on these patients. It is associated with other conditions, like OA, inflammation, fractures. But most of the patients are going to have some sort of repetitive stress. Like runners are a lot of what you see a lot of these conditions in are athletes that just have the repetitive stress. They're landing in the same area. And then this one is first MTP, plantar aspect pain on palpation. So here's like a nice little drawing there on that left, on the bottom of the foot, where those sesamoids normally lie. So this one, like dancers, is another common one. So people who are always on the balls of their foot, you're going to think about this more. Runners, you can see it with trauma, but that's like future problems. When I'm in the ER, I'm like, they see the PCM for their sesamoid problem. But on an exam, you're going to palpate under that first MTP. You're going to reproduce their pain. Then they might have some restricted range of motion, especially due to pain. And then you want to dorsiflex that toe, and they should have pain with dorsiflexion as well. Here's what it looks like on the imaging. And one important thing to remember is if we're worried about, if we're getting imaging for this and worried about sesamoiditis, we want to get a sesamoid view on these patients. That's like the one thing different from most of the other conditions. Usually like an AP and LAF weight-bearing film. This one, especially for like board questions, you want to consider getting that sesamoid view. Sometimes you can get a bipartite or a multipartite sesamoid. So did you guys talk about in the knee, like bipartite? So it's a similar thing here. So you can see that on there. Sometimes it could be confused for a fracture. One of the nice things, if you're worried about a bipartite sesamoid, we have 2 feet, so we can look at the other one, maybe it's the same, so that can be helpful too, especially if you're worried about a fracture versus a bipartite sesamoid. And what do we do again? NSAIDs, rice, wear better shoes. It makes sense if you have a high-heeled shoe, it's going to put more pressure on that first MTP, so it's probably going to worsen the pain. We tell them to avoid that, and then we get like a sesamoid pad for them to place in their shoes. We can also, a stiff-soled shoe can be helpful, so you have patients, which I have a lot of patients in South Texas that they don't wear anything but flip-flops, and they never will. So I had to give a surgical shoe for something stupid recently, because she was refused to wear anything but flip-flops, and I was like, well, it's going to worsen it, but here, wear this funky-looking shoe that I'm going to give you. I don't know why you would place a short leg fracture brace. I've never seen that, but apparently you can, and then you can do a sesamoidectomy or excision for refractory cases. Good old toe deformities. So we'll talk about, our hammer toe, claw toe, what some of our differentiators are on these, but we really have like 3 common types. And we have them listed there on the bottom of how you kind of differentiate them. And really, you can evaluate by where you think that injury is, which it looks super easy on this slide, right? But in real life, like toes are real small and you're like, is that a hammer toe or is that, I don't know if that's a hammer toe, I don't know if it's a mallet. So sometimes it can be a little bit difficult on your exam depending on how they present. All right, so here's what it looks like. And really you're evaluating where that deformity is, whether you think it's at the PIP, whether you think it's at the DIP, and then you also want to evaluate with their, like you can see on the one on the right, the mallet, you can get, since it's kind of pushed forward, you can get calluses and other issues on those toes, so we want to evaluate for that, or a corn, I guess you could be on there too. But really, if it's, sometimes patients won't have any pain with it, you'll find it instantly on an exam, but usually they come in complaining of some sort of pain with certain shoes they're wearing. And then you want to evaluate it, standing and sitting. So you want to look at the normal alignment versus the active alignment when they're actually standing. Then you just try to decide which joint it is, whether it's, at the MTP versus whether it's PIP or DIP for your different deformities on there. And then the question is what do you do with it? If it's acute, then you can look at doing some sort of referral for surgery. Most of them are treated non-operatively. What we need to consider is this associated with some sort of other condition like from diabetes? Are they controlling their sugars well? We want to do that good neurovascular exam on them. So peripheral neuropathies do contribute to this, so something we need to look at. And then what do we do for it? So most of it's non-operative therapy, so NSAIDs, RISE, activity modification. Once again, roomier shoes that seems to solve everything. If they have a corn on there, you can get them, we can give them some sort of padding to help decompress that area. Sometimes toe splints can help during the acute period. Because if it's one of those tendon slips or outside of its normal mechanism, we may be able to immobilize it and it can heal. Most of them we just send them to rehab and they'll work on seeing if they can improve it non-operatively. And then if it's causing an issue for toe alignment, then they might do operative repair for it. But it does have a lot of complications to it. They get persistent ulcerations with these, especially the changes at alignment and pressure in a certain area, which is why the non-op treatment with different shoes are important. And then we have to worry about anybody that has a high arch end-of-claw toe. We want to think about Charcot married tooth as well. Normally we see that, we might consider it in a younger population, but it's something we always want to consider on there as well. So they have the high arch and a claw toe, consider Charcot married tooth. All right, we're almost done here. All right, moving on to turf toe. So this one, it's caused a lot of missed playing time in athletes. It says more than ankle sprains, which I guess I didn't know that. With turf toe, but normally the classic patient's going to be they push off on a hard surface with their foot fixed in dorsiflexion, and then it can cause this injury. So it's really like a first MTP sprain following hyperextension, and you can kind of see where it affects that area at the big toe, most commonly in that artificial turf fields, which actually cause a lot of injuries, honestly. All right, so they're going to have, once again, swelling, tenderness, limited motion at that first MTP joint. This one's going to, obviously be associated with some sort of trauma or sports injury, so hopefully you can differentiate it from your sesamoiditis, because they'll have similar pain there. What's important to remember is the grading criteria for these. So if they have grade 1, it's just like mild stretch injury. So it's just mild pain, swelling. They can continue playing. When you move into the higher grades, like grade 2, it's a partial tear of that plantar ligamentous complex. So these patients will have, usually some ecchymosis down there. They'll have a little bit more increased pain with it, and then they'll have moderate swelling. And these ones will have a decreased range of motion when you start getting to the higher gradients. So these ones you want to restrict their play time at that point. And then the complete tear is usually they can't walk on it or ambulate normally with it. So there's just marked swelling and ecchymosis. They'll have limited range of motion. And those ones, it's just, good to understand that they're going to have a lot longer return to play time for that injury. So we don't want to send them back immediately. Some of the long-term complications, you can, it can result in like OA or a hallux rigidus. And then it could, theoretically result in instability of that joint as well. But it is something you always want to counsel your athletes on, so that we prepare them for whether they can return to play or not. But physical exam, you want to assess that range of motion. Can they ambulate? Like, are they weight bearing? That's always important. And then you want to get a plain film on these just to rule out any sort of avulsion fracture. If the diagnosis in question, you can get an MRI on these patients as well, especially like, we don't obviously do it in our normal outpatient clinic, but like sports, especially people playing on like semi-professional, professional sports team, they'll a lot of times get an MRI immediately after it, but we don't need to do that unless it's in question. And what do we do for this one? Pretty much the same thing as all the other ones. So NSAIDs, RICE, activity modification, physical therapy. Grade 1 and 2 you can usually fix with just the RICE. And then some stiff sole shoe or surgical shoe, which is what you see on there. And then that's just limiting that range of motion in that joint, so you're not worsening the condition or increasing their return to play time. And then for any grade 3s, we're gonna do some sort of immobilization for 1 to 2 weeks, non-weight bearing, and then it'll be a little bit longer return to play time for them. All right. So I know it was a lot, and I probably don't know it, but we'll do a quick review on this. So metatarsalgia, walking on pebbles is a good differentiator. They got forefoot pain, you can give them metatarsal pad. Plantar fasciitis, that's going to be first step in the morning. They're going to have pain on the bottom of their foot or the sole of their foot. They should have tenderness palpation over that calcaneal tuberosity. We do nice swing and stretching for them. Plantar warts caused by HPV. You want to remember, like, if it's disrupted those papillary lines, that's usually like pathognomonic for a plantar wart. And then pinch pain for the test. So if you pinch it, they're in pain versus a callus. And then salicylic acid first line. Posterior tibial tendon dysfunction. So too many toes sign. Don't steroid inject them. It causes flat foot. Sesamoiditis, think about it in like dancer, runner. They got pain on the plantar aspect of that first MTP, get a sesamoid view are the big things to remember for it. Toe deformities, your claw deformity involves all 3 joints, so you want to think about charcot-marie tooth, especially if they have a high arch. And then your hammer is your MTP and PIP, and the mallet's DIP only. So it is important to know which joint is involved with those. Especially for like board questions and test taking, and then turf toes at first MTP, hyperextension. What questions do you guys have? Does it seem all right? Do you guys feel comfortable? Because, yeah, I've never taught this before, I don't know, man. Cool, I'll hang around if anybody has any questions.